All right, welcome everyone. Thank you for joining us today. My name is Blair Elliott. I am the Communications and Events Associate at the McGill Institute for the Study of Canada. We'd like to thank you for joining us today for our webinar on long-term care policy under the microscope. Our event today is co-sponsored by the Center for Research and Expertise in Social Gerontology, which brings together researchers, practitioners, students, and collaborators from different practice environments around the same mission: to improve services and professional practices aimed at older adults. This mission is based on the development of social research, the development, testing, and validation of leading-edge practices, the Social Services and Health Intervention and Technology Assessment Unit, and on teaching and knowledge transfer activities. Today's webinar complements the article COVID-19 and Long-Term Care Policy for Older People, published in the Journal of Aging and Social Policy, and co-written by our two speakers, Béland and Patrik Marier, which you can now read online for free, and we'll be sharing a link to that article in the chat box. Patrik Marier and Béland, the two authors of this paper and members of CREGÉS, are here with us today to talk about it and take your questions. This webinar is being recorded. It will be uploaded online to our YouTube channel after if you'd like to rewatch it and share it. We invite you to use the Q&A box to type your questions in, and we will answer them during the question period after the discussion. To start us off today, I would like to introduce Béland, the director of the McGill Institute for the Study of Canada, and James McGill Professor in the Department of Political Science at McGill University. Take it away, Daniel.
Thank you very much, Blair. Bonjour tout le monde. I'm really glad you were able to attend today by this beautiful day, at least here in Montreal. It feels like summer and it's so great, despite all the gloomy news about COVID-19 and other things that, of course, we can't really forget about. I want to tell you that tomorrow at the same time, 2 p.m., there will be a French webinar, again, with Patrik Marier. It's like today, interview style. So I will really interview Patrik, have a discussion with him. So who's Patrik Marier? Well, bonjour, Patrik. I'm really glad that you accepted our invitation. Patrik is professor of political science at Concordia University and the scientific director of the Center for Research and Expertise in Social Gerontology. The acronym in French is CREGÉS. In Quebec is the land of acronyms, so we have a lot of acronyms here. But he's the scientific director of CREGÉS, and he's the lead researcher of the FRQSC funded VIES team, which specializes in social exclusion and aging. Patrik is really one of the best specialists of aging and social policy in Canada. He has a forthcoming book at the University of Toronto Press that's actually a comparison of aging-related public policy in all the provinces. He actually traveled to all the provincial capitals and interviewed government officials in all the 10 provinces to prepare that manuscript. And so he's one of the most knowledgeable scholars when we talk about aging and public policy in this country. Obviously, today, we will focus on long-term care for older people in the context of course, COVID-19. I think that it's quite clear that COVID-19 has revealed a lot of the flaws of long-term care as it operates in Canadian provinces. That's the case here in Quebec, but also in other provinces, although there is variation from one province to the next, something we'll talk about today. So first thing, Patrik, maybe you can tell us a bit more about CREGÉS and the VIES team. So what you're doing in terms of research and how this is related to the topic at hand today.
Well, thank you very much for the generous introduction, Danielle. So I'm happy to be here today and happy to discuss long-term care. Would have been better in rosier circumstances, but that being said, I think the current events are resulting in a closer look at long-term care that's been long overdue. First, I will start with CREGÉS. CREGÉS, it's literally the best way to describe it is a way that we can use practice to actually enhance our research, but it's also a way that we can use research to enhance practice. And at CREGÉS right now, we have 24 university researchers across Quebec from 7 universities. And what's really distinctive from CREGÉS vis-a-vis other aging center, we've got researchers from 15 different social science expertise, right? And that's quite very unique even in Canada. We also have, as part of our team, 4 researcher practitioners. Actually, I saw that 2 of them are there, Sandra and Zelda, and they lead our domains of expertise. So we have a domain of expertise in palliative care, one in caregiving, one in elder abuse, and a new one on inclusive aging, diversity, health, and well-being. So essentially how we operate is when we do research project and we help them off the ground, we make sure that we include research practitioners, researchers, and students as part of our way of operating. So we are hosting the CLSC René Cassin in the Seine-Ouest of Montreal. And we have currently 68 students. And we also conduct from time to time ministerial mandates. So it is CREGÉS, for instance, that did a lot of the background work for the caregiving policy that was announced last week. So you're mute, Daniel.
Yes. So as usual, and so I'm really happy to have you today. So I think it's important to have a start with the big picture, because when we talk about long-term care, it can mean different things. Actually, especially when you travel across the country, it has different meaning in different provinces. In Quebec, we talk about CHSLD. We have our own language. Ontario, the language is different. There are differences in terms of the nature of the providers and so forth. So what's long-term care for older people exactly?
Yeah, very good question. In fact, there are multiple types of housing for seniors, and I can show the slide with regards to casualties in Quebec. But essentially, a long-term care facilities, right, or in Quebec, the CHSLD offers a range of supportive service that aims to provide assistance to individual over an extended period of time. So that's long-term care in general. That has to be really something that it's not rehabilitation. So it's not when you come back from the hospital and then you do some training and exercise and you're back to pretty much your previous conditions. And it's also another important element that it distinguishes itself from acute intervention. So the aim, first and foremost, is not to cure or restore someone's health. So you're really dealing with chronic conditions, and then we're dealing with people who've had long-standing health, physical, mental health issues, and so on that are not curable. Maybe that's the best way to put it. And then when we talk about nursing homes, right, there are 3 major components. The first one is literally accommodation. So you tend to have a bed and a facility that is equipped to provide you the services. There's also an hospitality service element. So this is when you read a lot of the critique from many social actors is that we tend to undermine, this, undermine may be a strong word, but we tend to marginalize that dimension, because for the residents who live in a long-term care facility, in say HSFD or nursing home, it is their home, right? So that's why it's all the elements of the social activities, even your meals, the way you can host visitors and so on. It's all part of the hospitality services. And the last components are really the health services, right? So the reason why you're in a CHSLD in the first place is that you do need a high level of care, which makes it too difficult to actually provide these at home.
Yes, so this is a good overview, but of course there are, as I mentioned earlier, quite a bit of differences across provinces in the way long-term care is institutionalized. So maybe we can travel across the country and look at what are the key differences among provinces in terms of long-term care, and also how Canada more generally compares to other countries in the way we have set up our system, which is, of course, decentralized, so variation from province to province and territory to territory.
Yes, well, I will first start with a global assessment of what distinguishes Canada with regards to long-term care as opposed to the other countries. I will do a share screen first to show you some of the nice slides taken from the OECD Health at a Glance. And then you'll be able to confirm to me slideshow. So I assume you're seeing all the right slide, yes? So the first element that really distinguishes Canada vis-a-vis to the others is the fact that we're pretty much more in the bottom part as opposed to the upper part, right? So it's important to note that OECD countries increasingly include countries that are still industrializing or they're not that far along with regards to other industrialized countries. So Canada's a share of GDP, we only spend 1.3%, which is far from the leading countries, you know, such as Sweden, Norway, or the Netherlands, who all spend over 3% as a percentage of GDP. And that's a huge distinction. So in many ways, Canada for that is a country where we tend to provide basic needs, but not much more else than that with regards to long-term care. And that's why you're seeing a lot of reports from ombuds offices across the country. Most notably, there was a major lengthy inquiry conducted in British Columbia. There was a 2-book volume on long-term care that highlighted a lot of deficiencies, especially by international standards. And that's actually paved a bit of the way to the creation of the senior secretariats a few years later. And that's why that in many ways, we do not succeed in meeting the demands. The second element that is quite important is the fact that if you look at the one on the top here with my cursor, is the fact that Canada has a very heavily focused bias on institutional care, right? So nursing home, the CHSLD represents and has represented for over the past 20 years, 80 to 80% of all our funding on long-term care. And this is quite shocking to me when I first saw that, because I can tell you that every single senior civil servants I met across the country will tell you that home care is the priority, but yet it's really not shifting. We can talk about that a bit later. And the other elements that actually is quite striking, so considering our heavy emphasis on CHSLD and nursing homes, you would expect Canada to be one of the places where you have the most bed as on a share of older adults about 65 and above. And if you look, Canada here is among the lowest, right? Which is also another figure that demonstrates the extent to which it is quite marginalized as a policy area. So one would be very hard pressed to say that we have actually a generous long-term care policy with regards to the other countries. And then in terms of provincial differences, what's really noticeable is the fact that there are a lot of provinces. So we usually, typically, when we talk about the healthcare system in Canada, we say there are 13 healthcare systems. That's even more true when we talk about long-term care. So there are wide differences. And there's even in one province, it's not run by health authorities, but by a social development department, which is the case in New Brunswick. And also another element is that in terms of politics, you've had a lot more leeway than the other health sectors. And we get back to this, I guess, in a moment when we'll discuss about the role of federal government. But for political scientists out there, this is a clear case where partisanship matters, especially when it comes to the role of the private sector. So in Ontario, the major reform that had long-lasting influence have been under Mike Harris and the Conservative in the 1990s. And as a result, 58% of nursing home facilities in Ontario are operated by private companies, right? So the Extended Care, CNO Living, Chartwell of this world. 24% are run by nonprofit companies and 16% by municipalities. And even the share by municipality is dwindling down. That's kind of a historical legacy. However, if you compare with Quebec, only 17% of our beds are in private residential facilities as opposed to 83% public, which is why you can contemplate or even think about renationalizing nursing homes in the Quebec context, but this is clearly not the case in Ontario, where the private sector has a very strong foothold. But still, what's important to know, despite these differences with regards to the role and importance in the private sector, in all provinces prior to the COVID-19, it was steadily growing everywhere, right? Literally, so a lot of planning with regards to the construction of future CHSLD nursing home involved private partnerships in some shape or another. And part of the reason, in many ways, it's a cheaper way, at least in the short term, to actually be able to expand your capacity, which in some cases, if we look from some Quebec figures, studies show that we're going to need more than 196,000 beds in Quebec by 2050, compared right now to 75,000 beds. So it's over 2.3 times the amount of spaces that we currently have. So that's in terms of costs, right? We're talking to $3.2 to $8.4 billion. So that's definitely a key distinctions to consider.
When we, Patrick, thank you, Patrick. When we look at these different provinces, are there some provinces where we can say that maybe we can learn positive lessons from them? In our article, we talk about New Brunswick, for example, a province that, it's a smaller province. In Quebec, for example, when people look at what's happening in their provinces, they tend to look at Ontario, right? Yeah. But New Brunswick has an interesting system, and I think that we can draw lessons from it. So what do you have to say about this example, and maybe other provinces you think are doing at least some things well that other provinces can learn from?
Yes, well, New Brunswick does extremely well. It's been one of the few provinces that have had a very meaningful commitment to home care. And part of the reason is that they had a head start advantage when they developed home care in the 1970s. And it's been strongly embedded and institutionalized in the social development ministry. And what that means concretely to be this distinction between being in a social development ministry or social affairs ministry as opposed to a healthcare ministry, long-term care is the #1 priority in a social development ministry. It is by far the biggest budgetary expenditure. And concretely, this meant, with example, with regards to COVID, is that when they had that first emergency restraint cabinet meetings, the social development ministers was an integral part of these discussions in this meeting, along with, I think, it was the finance minister, a health minister, the prime minister, and also something quite unique to New Brunswick, they invited the head of the other parties, which is, I think, unique in Canada. As a result, a lot of the data will show that in terms of social-like expenditure or long-term care expenditure, it does significantly better than the other Canadian provinces, both with regards to the home care, and also what's very unique in long-term care, it has a strong roots at the local level that have been, that they continue to sustain. So you're very, very different than, let's say, in Quebec, where it is very much integrated in a healthcare system. And then you are literally competing, if you want to put it bluntly, right? You're competing in terms of prioritization of problems with the fact there are too many seniors at the ER, right? So the way you construct the issues sometimes with long-term care is that they take too many acute care beds, and therefore you need to find a solutions to actually not have them overclogging the emergency room. So the way you think about long-term care is vastly different. And also, if you look at the COVID-19 response from Quebec, right, there was no real long-term care individual head figures involved, although you have your Minister of Health, but the Minister of Health comes pretty much from a hospitality-centric kind of administration, and that changes a lot. So you can see that type of institutional setting tend to lead to marginalizations of long-term care. And if you look after the economic crisis of 2008, for instance, the number of beds in Quebec actually went down by 17% between 2000 and 2017. And whenever 2010, 2017, yes. And then as you saw some of this health budget restored, the long-term care percentage growth did not exceed that of other healthcare sectors. So that's a big difference between these two.
So you talk about COVID-19 and long-term care and the emphasis of on home care in New Brunswick and the lack of emphasis on healthcare in other provinces like Quebec. In terms of COVID-19, what do you think are the things that provinces could have done to be in a better position to actually address this pandemic from the beginning? Because in Quebec, I think the focus, you're right, was on freeing up hospital beds. So the focus of crisis management before it actually started was we need to free up hospital beds. And there was not much thinking at the beginning, at least explicitly in public, about long-term care. So how can we do a better job next time? How can Canadian provinces do a better job next time when addressing a pandemic?
Yeah, well, I think from a long-term care perspectives, I think it's important to have one person where their primary mission and what keeps them up at night is long-term care, has a primary focus, and make sure you find mechanism that these people are included from the get-go, right? And I'm sure in the wake of all these lessons, that's going to be something that will arise to the surface. Although it is very early to make a conclusion as to how we've responded, as how individual provinces have responded to that, especially since I don't know if this first wave is going to, continue, if there's a second wave and so on. But it is clear from the get-go that the British Columbia response from the get-go preventing care workers from working at more than one nursing home proved to be excellent, is actually really stopping the propagation or risk of propagation across nursing homes. While in Quebec, right, the more and more of the accounts and the more we get to know about it, that proved to be a major issue. So that's definitely one of the key elements. The other element also that came out of this is how crucial and how important caregivers play with regards to actually maintaining the well-being of individuals in the nursing homes, and how we have actually underplayed, right, or took for granted a lot of their support.
Thank you. Before we continue the conversation, someone asked that, I think, in the chat, about having a conversation like this in French. We have one tomorrow here at MISC, a Zoom webinar in French with Patrik Marier, starting at 2 p.m. So you can find more information about that on Twitter, on our website, and so forth. Patrik, we have talked a lot about how Canada stands compared to other countries. So internationally, how we compare. We are not doing so well based on the data you showed us. Then we look at how provinces compare with one another. But what's the role of the federal government in all of this? Because this, in our article that we just shared, that Blair just shared with our viewers, the participants, we say that COVID-19 is like a focusing event, something that draws the attention of the country, of people, of the media, of politicians on long-term care. And a lot of this attention has been focused, yes, on the provinces and what's going well in some places, but especially what's going not going well at all elsewhere. but there are also growing calls for greater involvement of the federal government in the field of long-term care. So first of all, my first question, what's the role of the federal government in long-term care as of now? And what are the different policy alternatives, the different options on the table to increase or recast the role of the federal government in long-term care?
Yeah, well, what's maybe the best way to describe the role of the federal government is that it contributes to pushing long-term care in the margins. The first element that it really stands out is the fact that long-term care is considered to be an extended services in the Canada Health Act. So as a result, there are no provincial obligation with regards to standard and regulation. So the only one that tends to apply, which a lot of provinces deal with what we call Agrément Canada, which usually tends to certify, right? It's kind of voluntary certification. But in a lot of provinces have mandated that, but that has not come from a strong, there's no federal legislations that oblige you to do this. And also what's very indicative of this push to the margin are that all the major federal commissions on healthcare, none of them tackled long-term care, right? Already that's something majorly missing. Another element too that has to do with the way we actually created our health system is that it is an hospital-centered model. Since long-term care occupies a very marginal role in a curative model, it has helped to push this aside as to a lower ranked priority. And also in a way where we focused a lot on specialization or specialties of medicine. It's important to note that geriatric, it's much more of a global type of specialty, right, as opposed to some of the others. And indicative of its place, it's also quite marginalized. So Canada does have much less geriatricians per 100,000 than other countries. And it's also, as a specialty, tends to operate more at the margins as opposed to some of the other specialties. So that's something to keep in mind. And another statistics that I like to show out to illustrate the differences, there are 10 times more pediatricians than geriatricians, right? And that's also quite revealing. And in many other areas too, in terms of now we having growing needs, we are tackling an increasing wider range of medical issues. As this goes on, if you are embedded within this hospital and specialized medicine model, it actually has the consequences of pushing long-term care more to the margins. And also another element unique to Canada, and some of it has to do with federalism, is the fact that our municipalities actually do very little when it comes to long-term care. And that matters a great deal because a lot of the study shows that the closer is the decision-making and the budget to the municipalities, the more likely you are to have actually a better funded long-term care system.
So that goes back to a key aspect of Canadian federalism, the fact that provinces are seen as creatures of that municipalities are perceived as creatures of the provinces, and they have limited fiscal capacity. But if the goal is, at least something you mentioned earlier, is to improve our reliance on service-based home care as opposed to institutional care, then what should be done? So you say basically probably increasing the role of municipalities, but is there something the federal government could do to create an incentive for the provinces to push more in that direction? What can the provinces, the territories themselves can do to move in that direction? Because in the end, it seems that it might also be cheaper to do that, right? What are you think the conditions under which we can actually promote more effectively home care as opposed to institutional care?
Mm-hmm. Well, it might be first interesting to start with the reason why home care has been so embraced, right, by all civil servants. The first element you pointed out, it is cheaper, right? So even if you go on the long-term care websites of the Ontario government, they literally list you the costs, right, per day, and shows you significantly that home care is definitely the way to go. And it's also a good response with regards to a lot of critiques have been with regards to institutionalized care in general. So not just for seniors, but for other people who had more special needs. And it's also the solution that has been embraced by most older adults, right? So there are very few, there are no older adults generally don't want to end up going to a nursing home. So and usually if you ask them where they want to live, and as they grow older, they tend to mention their home, but this is not universal. Another key element, if we think about a broader political economy angle, as we are facing an aging society, right, there's increasing pressure to ensure that we have as many individuals as possible involved in the labor market, right? So if you're having if you don't provide good home care services, studies demonstrates, like literally you are pulling individuals away from the labor market, most of all women, right? And that can take multiple forms. That can take a reduction in the number of hours, you refuse a promotion. So as a result, having a good home care service actually liberates a lot of individuals to retain their spot in the labor market. And it also has the advantage of formalizing care, which means you actually are providing a stronger recognition, and actually you make it as an actual profession with all of the benefits that comes along with it. So to go back to the question of the federal government, why they're not doing more? Well, in fact, they can give more money through the current mechanisms that we have, and then the provinces can decide how to spend that. But it is very difficult right now in the context to try to impose a pan-Canadian solution. So already when Justin Trudeau mentioned that on the television, I think within the same day, he had to backtrack and say, no, we will help the provinces, but the provinces will be able to actually use that money as they please to achieve goals of home care. So that's a clear element. The other element, as I mentioned earlier, so you've had a good 30 or 40 years where provinces have developed their own ways of running home care. So creating a one-size-fits-all would be actually very difficult, even if you have the best intentions of doing it.
Thank you. Now, an issue you alluded to a little bit is actually the relationship between work and long-term care. And in the social care sector, a lot of women disproportionately work in the social care sector. And also there is a strong presence of visible minority women in that sector. And an issue that was raised during the recent crisis and even before that was the working conditions of people in some long-term care facilities in the sector, people who have to work for different facilities at the part-time here and there, and wages in some cases were increased and were increased during the crisis, but people have long criticized some of the working conditions of the staff. Is this something that we need to do something about in a more permanent basis, not just temporary basis, as we are doing during this crisis?
I would say definitely. In terms of statistics, there's a recent article in the Canadian Journal of Aging, I think, that claimed that 50% of nursing home workers actually were not born in Canada. So it gives you an idea to the diversity of this workforce. And there's also a lot of studies that demonstrate that in fact it is one of the most hazardous jobs. So in terms of work accidents, in terms of stress level, it is a very demanding and challenging job, and yet it does not get that type of recognition, far from it. And it is, in many ways, my hope that if this crisis has served anything, would be to actually accentuate the recognition of the importance of these workers. So in a lot of interviews with civil servants, when we're talking about issues with regards to the care workers force, the lack of workers is actually brought up tremendously on multiple occasions. And in that case, the pay structure has been mentioned on multiple occasions. Like even in some interviews I've done in the States, they say, well, we are competing with people who work at Chick-fil-A, which is a fast food operator. So it clearly shows that the disconnect between the value of what they do and how we treat them on the labor side. And it's also important that it's not just the pay will not resolve everything, right? So there's in many ways people say, oh, just pay them better and that's it. But at the end of the day, there's also an issue with regards to the recognition of these individuals within their own work environments, right? So the care workers provide about 75 to 80% of care in the nursing homes. And yet they do not have a strong professional recognitions like the nurses or the doctors. They do not have a lot, we don't provide them a lot of discretions with regards of how they organize their time and their hours. They're rarely involved in commission discussions on long-term care. Already when we had this crisis at the beginning and say, well, how can we address this? There's nobody with that kind of background that was nominated among the 5 in Quebec. So I think there's a lot to be done with regards to integrating them better within the profession or within the entire structure of long-term care per se. Because in many ways we talk about how we want to move towards a more horizontal working environments, but in fact there are multiple barriers to achieve that in long-term care and in healthcare in general.
So staffing is certainly a big issue. Another issue that's discussed in the literature, but not as much in Canada as in other countries in the field of long-term care, is this idea of long-term care insurance. And major advanced industrial countries like Japan, South Korea, Germany, and France have adopted comprehensive systems of long-term care insurance. So what's long-term care insurance? And is it something that we should actually think about in Canada? I know right now in this context where we talk a lot about long-term care with COVID-19 and so forth, that some voices are actually asking for us to consider long-term care insurance. So how does it work? And would it be something we should consider here in Canada?
Mm-hmm. Well, so how it works, that's a bit like a pension system in many ways, right? So you would have a mandatory contributions from all the workers on the labor force. And once you come past the time where you have an assessment and you're in need of long-term care, then automatically you would be receiving funds. Could be literally monetary, it takes different form, could be monetary compensation. It could be in terms of a level of services and then it's paid directly from your funds. In some other cases, you can have a bit mix of the two. But what makes it very distinctive and what we've seen from countries that have developed this long-term care insurance, especially in South Korea, you saw an immediate boost in terms of spending in the area of long-term care. A building of new infrastructure also led to innovations. And I can tell you, for instance, it has had a big impact on nonprofit organizations, which now can tap into a much more secure sources of funding. So you can start thinking about long-term care in a much more long-term manner, right? So it makes you think more in a 5-10-year perspectives, as opposed to now where literally there's a lot of fluctuation and uncertainty with regards to how this money is allocated. That being said, if it were to be construed as an insurance, and if you look at what's going on in Korea, of course, now with the baby boomer like retiring and eventually, at higher risk to get into long-term care facilities, it raises a whole question of intergenerational equity, right, which would be raised in these kind of debates, which is also being raised in Korea, as opposed to the fact that we've already had to increase the contribution rate to sustain the system. And as a result, there have been a lot of cuts being made. Pardon me. And there's been a restraining of the type of services available.
Well, I will take on, Patrick, before you, so that you can drink your water. Long-term care insurance is something we see in, especially in countries that have a strong social insurance tradition. That's the case certainly of France, Germany, but also Japan and South Korea. How do you make a case of long-term care insurance in Canada? That would be something that will have to be done in each province, I suppose. How could it be organized? Is there ways, because there are different models out there in different countries. So what do you think would be the optimal way to do it, say, in a province like Quebec, Ontario, or British Columbia?
Yeah, no, actually Quebec is the one that studied this the most seriously. There was with the election of Régent Hébert as Minister of Health in the short-lived Marois government. But we're still not sure as to the extent to which the government intended on pursuing it, because there's a lot of resistance from most notably the Ministry of Finance, because it is construed as an additional tax on the individuals. So in terms of the logistic, I think it's not that complicated, especially to raise the revenues. But I think the question it raises to more about the condition upon which you can spend it, right? And how it is being spent. So in some cases, like in France, gives a lot of latitude that you can actually use it as cash for care, or even in Austria, you can hire it for personal services that you contract yourself. In other cases, it's much more institutionalized. The basket of services and the providers available is much more tightly regulated. So there are a lot of varieties and elements to take into consideration.
But as you said, although this can be understood as a tax, some people talk about payroll contribution or contribution. Typically, people on the left like the term contribution. People more on the right, they talk about the tax. But what's interesting here is what you said about South Korea is that when you have such an insurance, there's actually more money into the system, more innovation, and it becomes maybe a bigger priority overall because there's just more money available. Another aspect, of course, to make more money available is federal funding, as you mentioned earlier. But as you said, the popular form of federal funding will be without strings attached. So that will be hard for the federal government to steer the system as it operates in the provinces. What about the criminal code? That's something that the federal government can do. The criminal code is federal. And I know I saw a question, someone asking that, so I may as well preemptively ask it to you. But is it something that the federal government could do? That's a thing that the federal government could do, is to actually make elder abuse really a crime with, strong penalties, something to beef up the criminal code of Canada, something that could have an impact on long-term care, because elder abuse is something we have talked about a lot recently.
Mm-hmm. Well, there's one of the ways to deal with this would be to increase the regulation, right? Have a stricter control that could be imposed. But even then, like to make it a criminal offense already, it's quite a high standard already, right? Quite a bar to achieve. And elder abuse it's generating more and more attentions everywhere. But I don't think it would be a good policy tool, I think, as a way to actually really fix the systemic issues with long-term care. I think that would just really, it's something really more at the margins, more than anything else.
Okay, so because the problem is structural, it's just not some bad apples or some people who have
No, yeah.
criminal mind at work, and that's the way to fix the system. Now, another policy issue that's been discussed quite a bit recently is about inspections. And especially when we have private facilities like in Ontario and other provinces, but also public facilities, how often they are inspected. If they find problems, are these facilities really punished? Are the problems corrected? Recently, we talk about how some countries like Australia have much more stringent inspection regimes than we have here in Canada in terms of long-term care. Is it a way to address some of the problems, or again, it's a simplistic view that focuses more on, punishing the bad apples than trying to create a better system overall? What do you think?
Mm-hmm. Well, it's a good question. And there's a lot of different angles to that one. For me, what was quite shocking is that I talked earlier about Agrément Canada, where I'm forgetting the English word, but a lot of these institutions had actually very good agrément, had been inspected, and they were deemed to be quite good. I think even the CHSLD Héron, when I first saw the pictures, they had the nice big banner that they were accredited properly. But I think the major underlying issue here, and it has to do with privatization and the extent to which we privatize. Part of the problem that we have going forward, and if you study these big firms, there are more and more leaving the nursing home type of market to go more towards the seniors housing, where the profit margins are are more lucrative, right? So as a result, there's a lot of pressures for the big multinational to minimize their involvements in nursing homes. So it makes it very difficult to have stricter rules, stricter regulations without providing a higher compensation. So I think that has to be discussed. And it's the same thing with regards to home care. So as a result, especially for provinces that are much deeper into the privatization with regards to running nursing homes, that would lead to very uncomfortable discussions, and they have to decide, right? They have to find a way to make it a much more balanced in terms of providing better care, but without also making sure that the money you're giving to these companies are actually going in the right places, right? So that's a major issue. And in regards to provinces like Quebec, I think for me with COVID-19, the danger is that we accentuate further our spending on long-term care and nursing homes, right? When in fact there are dire needs also in terms of home care that are now only slowly getting reported in the media. And especially now, the way we've altered compensation and the wage for an individual to do the training for nursing home is actually resulting in individual working in home care or home support to actually quit their position and actually take this training. So there, we have to think about this in a very cohesive manner and think about long-term care broadly and not just in terms of nursing home or home care.
Yeah, that's important. When we talk about long-term care, we also talk about working conditions, we talk about training, we talk about, yes, fighting elder abuse and so forth, but all these issues are connected in a way. And it's good that you draw our attention on the big picture. One aspect I want to raise before we start taking questions, we have a lot of questions. I see them from time to time at the bottom of the screen, and we want to answer all or most of them at least. One issue that you have been working a lot with Équipe Vie and CREGÉS is biomedicalization of aging. And it's a pretty abstract concept, talk about biomedicalization, but it's something I think that's quite important when we talk about long-term care and when we talk about the current situation with COVID-19 and beyond. So can you tell us a bit about biomedicalization and how this concept is useful to understand long-term care, home care, and aging-related public policy more generally?
Yeah. So if you see a lot of multidisciplinary centers who do research on aging, as through times almost entirely shifted into health. kind of research center. So you see that. So it's a strong pull that, to put it succinctly, treats aging as a pathology, right? So the way you approach aging, you approach it as some sort of a curative disease, if I want to caricature even further, when in fact we should think about aging as, you know, just an aging process that has social, health, dimension, cultural dimensions, right, that are rarely acknowledged. And there's a strong institutionalizations of aging and health, and that has multiple consequences that are quite visible. Like in Canada, one of the most visible one for researcher is the fact that the Institute of Aging is firmly embedded in the Canadian Institute of Health Research. So if you look at international call, more years, better lives, and all the other industrialized countries, it is joints with a health research and a social base. Well, in Canada, it's only the Canadian Institute of Health Research that actually monitoring that angle. And as a part of an ongoing paper I'm doing with a PhD student, we've calculated about 92 to 93% of the CIHR's money on from the Institute of Aging goes to medical health type of researchers. Almost nothing goes to social science. And that's a lot more, let's say, if we look at Sweden, where easily 20, 30% of research will go to social science. Another important way to look at this is the administration of aging. So it's a bit like a game of chutes and ladders, but the ladders are for the health people, while the ladders are for the social science expertise and researchers. And if we look, a lot of offices of aging have been built as a result of a lot of pressures from seniors groups, for instance, to be away from health because they don't want to be considered as a disease. And in many ways, we're seeing a lot of these initiatives have eroded through times or transform into healthy aging initiative and then eventually transform back into a health minister. So they've been very, very, maintaining them through time has been a very, very big challenge. Another element that also speaks volumes with regards to the biomedicalization of aging in Canada is the fact that there was a wide reviews of gerontologists in the Francophonie recently. And what really came out strongly is that Quebec has a very critical lens with regards to how they approach social gerontology, and has a lot to do with the extent to which health perspective permeates aging and aging studies in general vis-a-vis other Francophone countries such as France. And another element based on our study that we just is ongoing right now, it had also even altered the way older adults think of autonomy, right? More and more when we ask them, what are your needs as you want to remain autonomous? Well, what does it mean to be autonomous to you? And what does it mean in terms of services? A lot of them are literally were citing elements from their assessment tool, which is mostly based on physical needs or physical loss, and also with cognitive impairments. So they rarely will talk about what are social dimensions or social needs that you would need to actually remain autonomous and continue to enjoy life in your age. And maybe one last one, because we do have a lot of questions. Another concrete way that it's being experienced in public policy is the fact that if you do home care, you have a shift towards more acute care home program as opposed to home care or homemaker services. So you see shifting of resources more and more towards the medical as opposed to the social needs.
So I think you made a strong case for the role of social sciences in aging studies and aging policy. It's not that obviously that the medical side is not important. Yes. We all know it's really important. But I think that aging is not just a biological reality or medical reality. It is a complete experience sociale totale, a full social experience, human experience that has so many dimensions. I think that social scientists and also people in the humanities can contribute to our knowledge about aging, and collaborate with people in the field of health and the medical sector to really help us develop a more holistic understanding of aging. Because as we saw during the COVID-19 crisis, people suffered, yes, physically, and many people died in long-term care facilities, but they also suffered from neglect, depression, all sorts of psychological and sometimes even moral issues that we have to tackle as a society, and that are certainly not purely medical in nature. Mm-hmm. So now I will shut up and I will let Blair take over the question period. I might still say a few things from time to time, but this is Patrik's show. So I will let Patrik answer the questions, but if he has any issues, he can call me to the rescue, or maybe I will try to bother him and ask more questions. But he knows this field extremely well, as you know, and I'm sure he can answer these questions. And so Blair, it's all yours.
Fantastic. And feel free, everyone, to keep submitting questions to the Q&A while we continue, if you still have questions. To jump off from your point that you ended on there, Daniel, Patrik, I know we talked a bit about training already, but I was wondering if you could talk a bit more. We have a question. Has there been much discussion around culture change in LTC coaching, or different centering in training for these new staff being hired going forward? And if not, should there be, or what are the opportunities to do so?
Mm-hmm. Very good questions. I think right now, while if we talk about the immediate, right, most of the attention has been clearly about, as we've said in French, les bras, right, about getting mostly staff. But it's clear that in the gerontology literature, the idea of culture change, or more patient-centered, or we should say resident-centered, if you're talking about the nursing home facility, has had quite a stronghold, I would say, in the field of gerontology and even social gerontology. And I think, unfortunately, that's pretty much all I can say to this point. I'm not aware of what's being delivered in the content, but I would actually, this very good question spikes my curiosity as to see to what extent is this being valorized or included in the training content of the individuals who are starting their training right now.
Great. We have a couple questions about the relationship between long-term care and dementia. We have a very useful stat here. 64% of long-term care residents have some form of dementia. Would you recommend home care for those people who have dementia? What is the role of stigmatization within this discussion? Could you speak a bit about
yeah. Well, it's an excellent question, because as I've been putting more of a strong advocacy for home care and more social type of based approaches, it is also important to note that in line with a lot of the medical progress or the types of interventions we've had nowadays, is that the individuals who end up in nursing home nowadays have far more complex, right, and diverse needs that they used in the past. Mm-hmm. And that brings up a lot of questions about end of life care, and it also questions with how to handle the population that will have a lot of dementia or dementia-related type of issues. And I think, and that's a very important question with regards to home care, right? So what is available or what can be done? A major issue has to do with the double-edged sword of regulations that we put forth. On one hand, we want these facilities to be as secure as possible, to have the highest code standards and in various disciplines that are involved with long-term care. But on the other end, this also stifles innovation, right? So part of the issues, and especially if you're talking with the patient with dementia with regards to home care, there's a lot of red tape, right, involved with regards of recreating or altering, right, the approach you have. like in Quebec, I think what's interesting are more, maybe there's ways to play with the ressources intermédiaires, which is kind of the halfway between a home care and a CHSLD. But these tends to be very, very difficult to navigate because of the fact that they are a lot of regulation in place. And those are not just health regulation, right? Some of them could be just pure, simple housing regulations. Or in some case, it can easily be as simple as if I'm altering my house in a certain way, it loses, $20,000, $30,000, $40,000 in value if I want to resell it. So it's kind of a no, we don't want to go that way. So there are a lot of elements and complexities involved that makes these type of debates sometimes much more difficult to enact than actually propose, right?
Yes, there's a lot of nuances in it, definitely. We have a question about cameras and technology. What are the pros and cons of putting cameras in long-term care homes? And how can technology be used to improve our care and communications?
All right, so we're getting into all of the major debates here. Well, the camera situation, so, well, first of all, the way we've set it up in Quebec, it's supposed to be the resident, it's your home, right? It's where you live. So based on that interpretation, so it is clearly up to the individual if they want to have a camera in their room. That's for sure. But on the other end, it also contributes, if you think of it from the perspective of care worker, right? It contributes to this surveillance culture, right? Of you being monitored and what you're doing being monitored. And in many cases, there's a lot of pressures with regards to how much time you spend per individuals. And I think that if people were really aware of right now our working conditions for care workers and what we expect of them to do for patients, and we had that film, I think people will be quite shocked that it's as little as it is right now. So I think these debate is actually quite difficult because you really have to think about it holistically, and also think about, all right, if you're going to monitor more the work on an individual, you have to actually make sure you provide the tools for the worker to actually accomplish their job, in the right manner.
Interesting. Okay.
But I fully understand from the perspective of the residents and of the family who's concerned about their loved one.
Of course. Yeah. Okay. Are there any discernible differences? I like this question a lot. Are there any discernible differences between the quality and prevalence of home care services between provinces that have had NDP governments over the last 2 to 3 decades versus those who have been led by other political parties? And this is a two-parter. Is there any political party that would earn the title of being the champion of home care services?
Oh boy. Huh. So, well, maybe I'm going to do a yes and no answer. Yes, in the sense that Manitoba is clearly a leader of home care and has been for quite some time, and had a lot to do with the NDP governments. And when the NDP even launched the study and commission of it, it actually had people who had a background in gerontology. So it's almost interesting to note that in the 1970s, and all the key figures were women too. So for that, there's a clear link. And to this day, home care is featured prominently within the mode of operations of the province. And if you look at a lot of indicators, it does stand out with New Brunswick. So the yes, but is the New Brunswick, which actually where the political color of the government has not had that much of an influence. But actually what mattered more was the independence of the civil servants who first proposed it. And because the province rely so much on career civil servants, less subject to the politicization of the bureaucracy, they were able to withstand critiques from medical organizations who actually were opposed to home care. And as a result now, the way it's been institutionalized within the Social Development Ministry, it has now institutionalized and anchored itself with more of a social and / home care approach to long-term care, which continues to prevail today.
Great. Okay, we have one more question so far, but if anyone else has them, feel free to keep them coming. So here's a question. Last week, the CBC did a comparison between Ontario long-term care with Australia's standards, inspections, and consequences to infractions. Australia has stronger standards and contraventions required correcting within 30 days or facing takeover to remedy the contraventions. These were private, public, and NFP. How far behind are we in Quebec to getting there, in your opinion?
Yeah.
If Australia was compared to Ontario, let's throw Quebec into this conversation as well.
Yes, I'm not as familiar with how they do in Australia, but I've seen the same report. Mm-hmm. But I think the key discussion, it goes back to the fact that regardless of how many inspections you have to make sure that you do have the proper budgets to actually operate at that standards, right? And you do it, the proper compensation to do it. And I think at the end of the day, especially if you think more Ontario, you have to negotiate with these big private providers. Mm-hmm. And I think some of it has to do with the sense that you are really stuck in a catch-22 now, because on one hand, you want them to provide higher standard, but on the other end, you're stuck with them. Mm-hmm. And it's as a result, from a political kind of point of view, it is really more about negotiations and changing the politics of long-term care and finding ways maybe to introduce more public sector, more community sector, more nonprofit, municipalities. So there are a lot of ways and innovative manners on which you can think to improve long-term care. But for sure, if you were to start to imposing kind of Australian type regulation, well, the first thing that would happen will be all the long-term care provider asking for more money.
Okay. We have a question that might get us to end on more of an optimistic note. Krista asks, are you aware of any success stories in terms of properly balancing restricting access to long-term care in order to minimize the viral spread, and also supporting family contact to allow substitute and supportive decision-making in alignment with the law, supplement care quality through family engagement, and maintain social relationships that enhance the quality of life in long-term care?
All right. Yes, fortunately, I know some of the good stories. Well, what comes out from a lot of the consultations I've participated in is the fact that in many, some of the small communities, right, there's more and more of an effort to actually build infrastructure that reflects more the needs of the individual, that is more, consult more the individuals involved, not just the residents, but also family members and friends, and finding ways to involve more and more of the community, right? So even in terms of the social activities, meal preparation, there's so many layers, and also a lot of grassroots movements where communities, and I think that's where we need to reach more to our local elected official, right? So if you're doing municipal events, well, then why not try and find a creative way to actually ensure that people who are residing in nursing home can participate in these. I think in terms of that, there's a lot of goodwill, but to talk about this at a larger scale has a lot of regulatory barriers that makes this a bit more difficult, and also in terms of access of funding, and making sure you hire more people who are like in social work field or leisure. I have a lot of colleagues who work in leisure and they feel marginalized a lot, right? So we tend to push them aside quickly as soon as we're talking about a long-term crisis. So I think these types of local initiatives, I think they can be replicated, and we can learn from one another through these, but very difficult to actually try to propose this on a province-wide level.
Great. Okay. One more question here. We talked a bit about the difficulty of finding a one-size-fits-all across provinces when we're talking about these issues. Barbara's wondering what best explains the differences among the approaches across provinces to dealing with COVID occurrences. Is it simply provincial politics? Is there cultural aspects to this? What else would explain these differences in that difficulty?
Well, as it's still ongoing, right? So people are throwing a lot of explanations, but that being said, I think it will take months, if not, years before we can address this properly as a researcher. But beyond what I stated a bit before, like the New Brunswick, where you have the long-term care minister, the Minister for Social Development, where long-term care is the main priority, at the table from the get-go. And we know there's a story in Actualité in Quebec where they were clearly not that kind of comparable. Another key element, I think, has to do with the leadership of the public health official, right? In New Brunswick, a lot of it has been said about the public health official. She had tears, but I think British Columbia was a lot influenced by what happened in Washington State, which were the first cases in the United States. So there was a lot of learning, I think, from what happened just south of the border, while Quebec seemed to have been much more geared toward what was happening in France and in Italy. And I think the public health officials seem to have been more geared or attuned to Europe. But that being said, I don't know what happened behind closed door, but it's clear if you look at the way that BC has enacted its response versus what has happened in Quebec, they seem to have been much more attuned to the realities of long-term care in British Columbia.
Right. Okay. I believe that is all of our Q&As that we have. Danielle, do you have anything else to add to any of this?
No, I think it was a rich discussion. Thank you very much for your questions. Thank you, of course, Patrik, for your answers and the discussion. Thank you, of course, Blair, for making this possible. And we'll be back tomorrow at 2 p.m. en français cette fois. And it will not be exactly the same content, but we'll deal with some of the same issues en français. So I hope that some of you will join us tomorrow at 2 p.m. I want also to tell you that, well, you can follow us on Twitter. It's MISC, M-I-S-C, C-A-N, so at MISCAN. You can follow us on Facebook. You can subscribe to our electronic newsletter, and you can, of course, visit our website. Just Google McGill MISC, and you will find us online. We will have a lot of interesting events, all online in the fall semester, including some webinars, and we'll put the information online soon. So the best way to stay in touch with us is to follow us on Facebook, Twitter, and or to subscribe to the newsletter. And I hope you will do so. And I hope that some of you will be back tomorrow at 2 p.m. Merci beaucoup. Bonne fin de journée. Thank you very much. Bye-bye.
Thank you.